the NHS Highland board on this windy, cold January day. Lovely to see your cheery faces. It feels like a very, very long time ago, but for those who I haven't seen yet, I hope everybody had a lovely festive break. But that does feel like an entire lifetime ago, if you can remember that far back. So just a little bit of housekeeping. You can see there that we are recording this meeting, and that is so it can be uploaded to the website in the future. And just to remind everybody, we do not use the chat function in this meeting. So if people want to contribute, make a comment or ask a question, if you could please use the hands up facility. Okie dokie. So before we get started on the agenda, I'm just going to take a moment to recognise a few people who were celebrated in the King's New Year's Honours List. So people who we know well, Dr. Tim Allison, who was our previous Director of Public Health and Policy, and as we remember, Tim retired in June. Tim was awarded an MBE for services to the NHS in Scotland. We also had Anne Clark, our previous vice chair of the board, and obviously, as we know, Anne spent many years on the board chairing lots of different governance committees and being really involved in our community partnerships as well. So Anne was awarded an OBE in recognition for her services to the NHS. I'd also like to extend congratulations to Professor Angus Watson. So Angus was the clinical lead for the Scottish Capsule Programme, and Angus was awarded an OBE for services to research and surgical care. So it was a lovely, lovely start to the year to see their contributions to the NHS being recognised. And as we know, just three very talented people of many, many talented people who work in our organisation. Dedication and innovation every day. So it's lovely just to mention those three in those honours. I'd also like to congratulate Nathan. So Nathan, as you all know, is taken up his new role as the Deputy Head of Corporate Governance. We know Nathan very well. He's a familiar face around this table, but Nathan's now taking up that new role. And I'm really delighted that Nathan will be working with Dom and the team and supporting us with our very large portfolio of governance work. So we're very pleased about that, Nathan. And speaking of Nathan, over to you. Do we have any apologies, please?
Yeah, thanks, Sarah, and thank you. Yes, we have an apology from Heather Bain. I don't have any other formal apologies for today's meeting.
Okay, that's great. Thank you very much. So next, I'll move on to declarations of interest. Okay, I'm not seeing any hands up there, so I will assume there are no declarations to be made. So that takes us on to item 1.3. This is the minute of our previous meeting, which took place on the 25th of November, and we have the action plan as well. So we'll just take the minute. First of all, does anybody have any matters of accuracy that they need to flag? No, okay, so we can accept those as an accurate record of our meeting. I'll move then on to the action plan, which I've definitely got open here. Okay, so I'm happy to take comments, questions, or anything that people want to add. The one comment I was going to make is I was looking down the action log, we've got a lot of actions, in fact, possibly all of the actions with a due date of March. Now, that might be achievable, that's great, but just checking that is the case. Maybe we need to review that, and I suppose if that is the case, just Nathan and Dom, for yourselves, I think there are a few things which refer to either kind of other committees or board agendas or development sessions. So if we are still on track to have those things completed by March, we just need to make sure that the appropriate committees and development programmes are going to accommodate that work as described in the action plan. But if anybody else would like to raise any comments, Emily, please.
Thanks, Sarah. I just had a question about the corporate parenting action, because I know we discussed that maybe being updated to Population Health and Planning Committee, but I believe that committee wasn't sure whether at least the annual report should come there, because it didn't seem to fit naturally within the work plan. So I guess I just didn't want to lose sight of it. It doesn't really matter from my point of view where it goes, but I'm not sure whether Population Health and Planning Committee did actually sort of take that on, if you like.
Okay. And I think there was almost kind of two parts to this, wasn't there? There was a bit about the home for the report, and there was a part about sort of board development and awareness. Now, somebody else might jump in and correct me if my memory serves me wrong, but I think offline we'd had some conversations about what that development session might look like to cover the corporate parent responsibilities, but actually maybe broadening to cover other board responsibilities as well. But I don't know, Gareth, I'll bring you in because your memory might be sharper than mine.
Yeah, so we have had some discussions around a number of the duties that we have a responsibility as a board to make sure we input to, and they're multi-agency in nature. Corporate parenting plan is one of those aspects where we work with other organisations to develop that plan. So there are two parts to it, as you said, Sarah. One was to discuss that as part of board development session to explore the duty itself and the responsibilities of the duty, and the other was to clarify how we get oversight and assurance for something that is a multi-agency piece of work. So that is currently, we will come back in March with an updated board work plan in relation to these items that are duties for the board, and we're still having those conversations about where they might go in terms of which committees. So that's a work in progress.
Okay, thanks, Gareth. So what we'll do then, I'll maybe take that offline with Gareth and Dom and Fiona. We'll just make sure that we finish that work that Gareth has just described, and we are simultaneously having conversations about board development sessions anyway, so we can make sure that we pick that up as part of those conversations, and we might have an opportunity in the next couple of months to sort of see where that's going to live, both in terms of development and governance as well. Okay, so let's update the log to reflect that. Okay, any other comments or questions about the action log? No. Okay, so yeah, I think we just need to check all of those, conscious of that heavy March deadline, and let's take that offline as appropriate. Thank you. Okie dokie. Oh, do I want to save it? Yes, go on then. So any matters arising before we move on to the rest of the agenda? Oh, okay, lovely. So I will move us on then to item number 2, and I will invite Fiona to take us through her Chief Executive's report.
Thank you, Sarah, and good morning, board members, colleagues, and any visitors that we have to today's board meeting. So at this time of year, systems pressures are at the forefront of the focus of our organisation. Early flu in December meant that our surge capacity was utilised earlier than usual. And my thanks go to the staff and public that tolerated the reintroduction of PPE face masks to limit the spread of the virus. As I mentioned in my report, I visited Regmore during this phase, seeing measures that we've developed to improve flow in our operations, such as the same-day emergency care and the frailty service whilst I was visiting the medical area. I also spent time with clinical staff hearing both the positives of these initiatives, but also the pressures and negatives of the ongoing and when we have peak pressure, and how staff feel at such times. Whilst I cannot offer an immediate resolution, I remain determined to keep listening whilst improvement work both in the hospital and beyond in our community health and adult social care services are planned and implemented. And as though early flu was not enough, we experienced a prolonged bout of snow in the first half of January. Our own health and care teams mobilised a Care for People response, particularly focusing on Caithness and Sutherland. I'm very grateful to our local resilience partners. In the lead was Police Scotland, but alongside us were Highland Council, Highland 4x4 Response, the Maritime Coast Guard Agency, Scottish Fire and Rescue and Bear Scotland. Many colleagues went to extraordinary lengths to ensure that those who were most vulnerable were not without care. a huge challenge given the concurrent vacancy rate that we have in our care at home services. We will be reviewing our incident response for learning and plan to build further our resilience for such events. Since the last board meeting, the early stages of the subnational NHS planning and delivery arrangements continue to be developed. I've agreed to co-chair the Finance Planning and Workforce workstream for Scotland West, with an early focus on consolidated finance plans and the business systems business case process. Colleagues from teams in NHS Highland will be joining other work streams, ensuring that our local perspective is reflected through the activity of the groups. Development of the formal governance connection continues to be planned and will be brought to the board in due course. Moving on, NHS Highland have reached an important milestone in our climate emergency and sustainability work by completing our first annual report. We have seen greenhouse gas emissions increase by 10.64% from 23-24, but we've seen a decrease in medical gas emissions by 13.7%. and waste to landfill decreased by 45.95%. Many sustainability initiatives are underway, so further progress can be anticipated. So well done to the team that have delivered the work and the report, and to their board champion, Jerry O'Brien, who's obviously on the call today. Finally, a good news story for me to close with. And in my report, I've highlighted a local patient, Chris Caldwell, who has had 4 joints replaced at the National Treatment Centre in Inverness. Chris has kindly let us share his story with us, and we wish him and his family well for his future health. And a really huge well done to the team at the NTC who are making these life-saving interventions in the lives of people who want to get on with their increased mobility and flexibility after their procedures. Thank you, Chair. I'll close there for any questions.
Thank you, Fiona. And yeah, thank you to Chris for sharing that story. That's fantastic. And I think we've all had the opportunity to see the great stuff that happens at the National Treatment Centre, but it's fantastic to hear it, you know, through one person's lived experience and the difference that it makes. So that was really, really good. Also, just before I open up for any other questions or comments, I just wanted to echo the points you made there, Fiona, about that resilience response to obviously the adverse weather, and just wanted to share that the bit around partnership working and how well the partnership kind of leapt together to respond to that. So I was at a community planning partnership development session last week, the week before, I have lost all time. I was at a development session recently, and the other partners around the table were talking about it in a similar way that you have, and it was really phenomenal to hear it from their perspective. And in fact, the Highland Council got some really great stats for kind of the work that they did to put some quantities around it. But what was more impressive than the stats was just that kind of that partnership response. And somebody used the phrase kind of Team Highland, and everybody so was really behind it. So it was just great to hear it from their perspective as well. And I think just shows how well we can work in partnership in those situations and how quickly we can respond when needed. And just to echo your comments, a huge thank you and well done to the staff. I know people went so far above and beyond. It's unbelievable. And within the communities as well, those community responses. So I just wanted to echo that. I'll open up. Does anybody have any questions or comments on Fiona's report today? Joanne, I'll bring you in, please.
Thank you. Thanks. Fiona, I welcome our input into the subnational work. I just wondered if you could give assurance that the additional work streams that you're taking on under the subnational work will not impact operations within NHS Highlands services. Thank you.
Thanks, Joanne. I mean, it's early days, and I've just only chaired one meeting so far of the finance and workforce and planning work stream. It's hard to know how much of my time personally that will take as I commit to undertaking that work. But myself and the executive team have had conversations that there may be things that I'm currently doing that will need to be delegated to others. We're in the fortunate position that not all boards are in, that our executive team is full. We don't have any vacancies at the current time. And obviously most of our team have been here for longer than I have, with a couple of newer faces. So I'm fortunate to be surrounded by experience within this organisation as well. So my hope would be that between us as an executive team, that we're able to flex streams of work and portfolios to be able to accommodate this work, because of course the purpose of the work is to draw strength from working in a broader group to help NHS Highland with challenges that we can't fix by ourselves. So one would hope, as well as a contribution, that we also gain a benefit from the work that's undertaken. So I don't know that I can offer the assurance in the way that you've asked, Joanne, but I can offer a hope and an assurance that we are having the right conversations about balancing the work of this board with the work that's being requested through the subnational committee. Thank you.
Thanks, Fiona. Good question, Joanne. And yeah, we'll see how that unfolds. And I suppose what I'm really mindful of is that it's really important for us as a board to be well engaged with that work for all the reasons that Fiona has described. And I think what's hugely important is that the Highlands and Argyll and Bute and indeed the broader issues that are faced by rural and island boards are represented in these national and subnational forums, so that we can make sure that, you know, whatever unfolds is cognizant of the needs of those people. So I think you're right, Joanne, it's something that we need to kind of be aware of, and Fiona and I will keep a watching brief. But I suppose I'm from my perspective very glad that Fiona is fully engaged in the work. I think it's going to be of real benefit to us going forward. Okay, Alex, I'll bring you in next, please.
Thanks. Yeah, it was just to build on your point that Fiona made, and you made about the response to the snow incident. It just so happened at the last FRP at the beginning of December that we had an update on the business continuity and resilience, and in there we talked about the resilience and incident response framework, which allowed people to do, it was a single point of reference. And I think by accident rather than design, we got to use it an awful lot earlier than we had anticipated. But the good thing was it really worked, and it worked as a partnership, and it worked as it was supposed to, according to the presentation that we got. So it was good that it's there. Obviously, there's more training, etc. But clearly it works, and it's something that we need to work with and develop. Thanks.
Yeah, absolutely, Alex. It really got tested in January, didn't it? I shouldn't speak too soon. January isn't quite over, but yes, it has been well used. Janice, I'll bring you in, please.
Yeah, thanks, Fiona. That was a really positive update, given all the challenges that we've had with the weather and everything else. So incredibly proud of the response that we had. So just a couple of quick points. So it was great to hear that story about the Chris, I think his name was, who had the joint replacement. So I think that's brilliant to hear. And I guess we can expect maybe through the regional work that actually the areas that we are more challenged, well, we'll see that reciprocal benefit. So don't need to answer that because I think you partly answered that anyway. But my other point was around about the climate work, and I wondered, it's maybe a question for Richard, but I wondered whether we take into account benefits that we get through telemedicine or telephone appointments, etc., and the reduced travel that then incurs, and whether that's part of our measurement. So it's just curious. I was just curious.
Thanks, Janice. I would agree that is a question for Richard. So I would concur with you. Richard, are you there? Are you able to respond to that point?
Yeah, thanks, Janice. Yes, it is something we take into account. So under the Environmental and Sustainability Committee, we've got a number of subgroups. So a lot of the subgroups are focused on buildings and fleet, but we do have subgroups like green theatres. We've been speaking closely with our public health colleagues as well to look at how we can capture that data, because it's quite hard sometimes to capture that data. And part of the work we're doing over the next year is building a more detailed environmental management system where we can feed that data in and actually get the carbon capture back out of that. So it is something that we are aware of. We have brought all the various work streams under the umbrella of the committee, and it's now just a case of translating the good work they do into how that will decrease those carbon emissions.
Good to hear. Thanks, Richard.
Thanks, Fiona. Thanks, Richard. Okay, I'm not seeing any other hands up. So thank you, Fiona, as Janice said, for that positive report. And we will note your update. Next up is a new item, or rather a return. So I'm delighted to see that we're bringing back the spotlight sessions. For some of us who have been on the board for a little while, remember we did these in the past, and they were a really great way for the board to hear from teams and services, understand the challenges, hear what's going well, learn about new innovations, and I suppose importantly for us as a board concerned with strategic delivery, understand how the work that we do connects with the work that happens out there in the real world. So I'm really delighted that we can be bringing this back. Today there's a slight amendment to what you see on your agenda. So today we're going to have one spotlight session, and that is on the Drug and Alcohol Recovery Service. And I'm delighted that we have Leslie Campbell here with us today to take us through the spotlight session. So Leslie, I'd like to invite you to give us your presentation, please.
Thank you very much. I'll just share my screen, and I hope you can see that. Hopefully the slide is coming up. Everyone see that okay?
Yes, that's perfect.
Thank you. I'm just going to turn away from you, so I'm going to put my camera off. Okay, so hello and welcome to Caithness Drug and Alcohol Recovery Service. Mary, Bob and I would like to take the opportunity to thank you for inviting us to present our spotlight with you today. Did you know Scotland's drug death numbers per head of population is second only to America and twice that of the remaining UK countries combined? Moving on. There we go. In case any of you are unfamiliar with the area of Caithness, it's located at the most northerly tip of the UK. Please don't be fooled by the remote location, however. Our story starts with the Drug and Alcohol Recovery Service, which was established in 2005. We receive an average of 170 referrals annually with varying degrees of complexity. I would argue similar to that of an urban drug and alcohol team, and certainly similar to our counterparts within the Inverness area. The population itself is diverse, with both high earning potential due to Dounreay being the biggest employer, with low costs of living, and high levels of social deprivation and unemployment within those groups. We face challenges with people accessing services and have no local third sector dedicated drug and alcohol service. In mid-2021, immediately after the return of normal services following the pandemic, drug and alcohol recovery services were challenged with the medication assisted treatment standards, the MAT standards. This was because of the year-on-year rise in drug-related death. This mountainous task continued over the last 5 years. Despite there being 10 standards, we were initially tasked to meet the first 5: same-day access, choice, outreach, harm reduction, and staying within treatment. The team accepted the challenge, we benchmarked ourselves against them, and began a quality improvement journey to improve drug-related harm through assertive outreach. Just move that on. So immediately the team were struck by a question. It's quite a simple question, really. What does high risk of drug harm mean? We thought we knew. All the answers were different within the team. And we thought, well, if we're only one drug and alcohol team and we all say something different, what are the wider services and members of the public going to say to that question? And how do we support services to identify people at need of outreach? In 2022, we began exploring how to identify someone at risk without requesting too much information. We distilled what we knew from local and national statistics regarding drug death and combined it with what we have learned from our police custody colleagues. Police custody is a fascinating, interesting and unique environment where you have 3 different organisations co-located, sharing just enough information to ensure the safe care of one individual. And from there, our trigger checklist was born. Using a low threshold approach and supported by the Caldecott principles, we are able to get enough information to commence the outreach process. Additionally, we had to recruit additional staff on fixed-term contracts to ensure safe and timely responses to triggers received. So, as you can see, the process is really quite straightforward. But in all seriousness, however, these flowcharts, along with their associated SOPs, support standardisation and work by stepping up from one another. So the first one that you see on the left-hand side of your screen is how the trigger checklist works. Once we receive the trigger checklist, it is triaged by a nurse or a social worker, and they answer a set of questions. Are they open to the service? Have we got a risk assessment? And then they decide whether outreach is appropriate. Once outreach is decided, we move on to the middle flowchart. We hand that trigger checklist over to our support work team, and they then make contact with that person. And my colleague Bob will explain exactly what happens when they make contact and what they do. But they will continue to try for up to 7 days through phone calls and doorstep visits. Once the outreach is successful, hopefully it's successful, and a self-referral is taken for that person, they would move on then to the third process, which is our normal referral process, where we would make contact with the person to do an initial triage assessment and then book them in for a full drug and alcohol assessment. So I'll let you now hear from Bob and Mary, and they'll tell you what this means in practice.
Thank you for that, Leslie. I'm Bob, one of the support workers. There is currently 4 support workers in the CDARS team, 2 of which are based in Wick and 2 based in Thurso. I've been in the role for 9 months. My colleagues Sarah and Tegan are just over 3 years each, and Willie is the daddy of the team with 23 years of experience of being a support worker. The role, as Leslie said, of the support worker is when we receive the trigger checklist, we'll do an assertive outreach to the person. We will try by phone calls, and if we can't get them by phone, we will do a doorstep visit to the person. Doorstep visits are carried out with 2 support workers. When we do an assertive outreach on the doorstep, we're basically asking them if they would like to self-refer into the team for any assistance. If they are not wanting to self-refer into the team, we will still offer harm reduction services to them. So that can be injecting supplies, foils, water ampules, etc. We will also do naloxone, offer naloxone, and if they are wanting naloxone, we will train them in naloxone as well. So that's probably the biggest thing that we do is the naloxone training with them. We offer that service and the harm reduction supplies whether they want to self-refer to the team or not. So quite often it's a good first point of contact whereby they'll take naloxone from us, we'll do the training with them, and then they may then refer back to the team at a later point because they know it's a familiar face, it's a friendly face, they're not being judged, they can get the supplies that they need with that. So as part of that service, we do quite a lot of work with clients. We can do referrals to food banks. We will do the wedding off service, whereby if they have bought drugs off the street and they're not sure of what they actually are, we can assist them fill out the forms and send it away to actually have their drugs tested so they're aware of what they are actually purchasing and using. Also, normal things that we deal with is referrals for housing, bus passes, and assistance to meetings, and social integration is another one because of quite a lot of the time our clients are isolated and don't know where to start on the recovery journey. So by assisting them to do social integration work as well, that also helps. So That's a brief summary of the role of a support worker, so I'll pass it on to my colleague Mary.
So I'm just waiting for the next slide. Okay, so this slide provides a real life example of a patient's journey in our service. So on day 1, we have a patient who attended ED. They were admitted to hospital with a drug-induced psychosis. By day 3, the patient was seen by DARS outreach through the hospital liaison. At this point, the patient declined referral to our service. However, later that day, the ward triggered the patient anyway. The patient was outreached again the same day with success. At that point, the patient was offered naloxone and a self-referral to our team was taken. On day 4, contact screening was completed by a nurse, so that's our triage. We then have a gap from day 4 to day 20. That was due to the patient not engaging, and then we had public holidays over the Christmas New Year period. However, day 20, we did get an initial assessment completed, and we got a plan to commence OST at that point. Within a week, that patient was successfully commenced on OST, following a successful titration onto methadone. By day 32, that patient had started relapse prevention work and further recovery planning. So all that links into the MAT standards. Thank you.
Thanks, Mary. So after hearing about the value of from the care perspective, we're going to look a little bit at the data. We receive localised, automated, non-fatal overdose reports from Scottish Ambulance Service. This is the data that we use, and it's the only data that we use for the days between chart, because we know it's the most reliable data source that we have for NFOD data. So that first, the biggest chart, is our days between chart. You will see from incidents 1 to 28 were prior to our project starting, which ran from January 2023. This is our baseline data and demonstrates the highest number of days between incidents was 48, with a median of 1 NFOD every 6.5 days. From point 29, you can immediately see that we leapt to 2 periods of almost 100 days, 90 and 101 respectively. We did not believe this was due to us at the time. Over the period of the initial project, however, we reduced our incidents by 2/3 from the previous year, from 29 incidents to 9. The median also rose to 24.5 days. The variation that you see in 2024 and 2025 correlates to the periods when we had less support workers in post, which is why we're delighted to have finally been given permanent contracts for those 2 additional support workers. The other 2 charts demonstrate an increase in self-referral since the project began, with no additional unexpected demand on the service. And finally, it's fair to say I'm incredibly proud of this team and what they have and what they continue to strive for and achieve. From Mental Health Nursing Forum Awards to permanent contracts and published work, they are striving for more. And we've even been on BBC Alba. So what's next? Well, as you can see, we're actively supporting this process to be adopted wider across Highland and beyond. Ultimately, the team, however, want to improve the care that they provide to a largely isolated and stigmatised group. They have plans for everything from widening access of public health priorities to psychological therapies. But I'll leave you with one final thought. The team were asked, do you want to prevent death or get the data for the project? Their unanimous response was both, and they did. So I'll pop my quick camera on and I'll ask for any questions anyone has.
Oh, that fantastic. Thank you so much, Leslie and Bob and Mary. That was really, really interesting. I've got a lot of questions. I'll open up. I'll see if other people want to come in. But that was really, really good. And I think I have seen some of the other teams in Highland, but that I hadn't seen your particular team's report. So that was great to see that. And that data was really compelling. Okay, Muriel, I'm going to bring you in first, please.
Thank you, and thank you to the team. It's actually it makes you proud to know of the level of dedication and work that you've committed to. What I would like to see is how can we expedite this being rolled out, because we've got pockets of this need is across NHS Highland, and how can we accelerate that and support you and your team to help us do that?
So I had really hoped that my colleague Bev Fraser, who's the strategic lead for drug and alcohol in Highland, could have been here today, but she's actually on holiday. We're working really closely with Bev and the rest of our DARS colleagues to share and spread this. In Sutherland, which is also part of my own teams, they are using this and trying to spread it across their community services. I think with any with any quality improvement project, it's really difficult to lift and shift. And we come up against all kinds of very interesting dynamics and questions and roadblocks. And I can give you the example of the work we did within the emergency department. So part of the second half of the project, the part I haven't really spoken a lot about actually this morning, was a second project that deep dived into the emergency department and looked at how we better work across our boundaries within care. And that was a project that was funded by the Q community and was done between ourselves and the University of the Highlands and Islands. It is actually it's been submitted for publication, it hasn't actually come out yet, but it looks at it was a realist evaluation to see actually how are things adopted by teams, and there was very interesting. Actually, a lot of it we kind of know, it's about relationships, it's about relational coordination. Our support workers actually go in and do hospital liaison as part of this outreach process, and that supports other professionals to understand, to provide the information, to have people outreached. So it's actually, I think, in part, it's about building the relationships with all the services so that they know that they can trust that it's okay to give the information. People still have a lot of fear around sharing information and what might happen to them when they share it. We have a bit more of a difficulty with prison and custody, and that relates to a lot to do with the systems within the prison and custody, prisoner rights, etc. So yeah, there's pockets everywhere, but I think it's absolutely the focus of the service to continue to spread that. And things like general practice, it's available there, to be used. We've done a lot of the work up here, but anyone that wants to adopt it, it just gets sent into the Inverness, the NEST team, and they would spread it out to whichever a team needed to do the outreach. So it is there for services to adopt and use.
Thanks, Leslie. I'll bring Alex in next, please.
Thanks, yeah. Thanks, Leslie and team. That was an excellent presentation. A couple of questions. First of all, I live in Thurso, so we're local to the area. What's the impact of the closures, or rather part-time requirements for the police stations within Thurso and Wick? Are you seeing any impact for the call of your services through that? Because obviously custody isn't something that is happening all the time now. And then the second question is, it's good seeing the reduction in harm and the time between harm. Have you got any access to actually rehabilitation facilities? I know that Scotland itself has got some rehabs, but much further south. Is that something that you can tap into, or is that goes through a different route? Thanks.
So no, the first question about police and police custody. The police were and police custody were one of our stakeholders when we first started trialling and testing the trigger checklist. And our custody colleagues in Caithness are reliable in providing triggers up here, when they're called in to see, and we know it's not a manned service, but when they're called in to see somebody and they have concerns, they will trigger them into the service. Police Scotland themselves, it's an ongoing kind of challenge, I think. They have their own systems, and part of that that has come up a lot of times is this balance of power. So they still use the vulnerable persons database reports, which go through social work. They can take a long time to get to us before it turns into a trigger. And we have been working on reducing that time frame. But yeah, it is tricky, but we have a really good relationship with them. I actually went in a number of years ago now, and I was invited into the police in Wick to train them for their naloxone handling. So they were one of the original pilot places for the police naloxone programme, and it was myself and the team that went in and did the training with them. And the other half of your question related to rehab, we actually have a rehab through Crossreach in Inverness that we have access to. That would be our first protocol for anybody that was looking for rehab services, and that's block funded by the Highland Drug and Alcohol Partnership. But if that wasn't suitable, then it would go through our consultant, and we can look at a business plan to have them go to rehab anywhere in Scotland. And
Thanks,
I think the
Leslie.
waiting lists are a lot shorter. They are reducing the waiting lists, and there's a lot of changes happening within Beechwood House and within rehab. They're changing their business model and things.
That's great. Thank you, Leslie. I've got Janice next, please.
Thanks, Leslie. Mary and Bob, that was excellent. And
Thanks.
amazing work, really. Great to see how you're using the data. And I think when you lost your support workers and were able to see that, we need to see more of that, really. That kind of real connection with the people and the outcomes that you're getting. I loved the bit about door knocking and the fact that you're making the links with other services, because I think as we try and deal with some of the inequalities as we go forward, I think some of the lessons that you've learned will probably apply to a whole load of other things, and door knocking's not something that happens very much.
No, and it was a real it changes your whole outlook, like the whole concept of how you look at services, I think, because we imagined that this trigger checklist would be used by other services, given to us, so it was still a referral in kind of thing.
Yeah.
And it wasn't until we started using it and we started looking at, well, they've triggered in that person, or there's been an NFOD for this person, but we know they're friends. We know that X, Y, and Z who haven't been attending are friends with them and probably were there at that incident. And we were like, we actually need to trigger them ourselves. And there became this shift, this mental shift of, actually, we know stuff, and there's no reason why we can't actually just go out and say, that was really rubbish, what happened to you? Is there anything we can do to support you? And so that mental shift, I think it was really powerful.
It's brilliant to hear.
And it was I think for the patients or service users, I think it was as powerful as when we first used naloxone and we were training people. The message we got at that point was, what, you really care that much? You care whether I live or die. And that was the same message that we were getting. Wow. Because initially when we knocked on the door, they're like, are you the police? And we're like, no, but that's the only people that really knock on the door, isn't it? So it really is. It's a very strong message of, we care about you. That's why we're here.
Yeah. Well, hopefully we'll see loads more of that in the future. Yeah. My only question was that the data really shook me at the beginning, because I thought I didn't really know that we were so bad in Scotland. And I wondered, I maybe should know this, but I don't. Is there a difference between our urban and more remote areas in Scotland to the size of the issue, or not?
I think for Highland, we see a difference in that they're younger people that are dying. In other areas of Scotland, it tends to be your 25 to 45 30 to 45 year age group, but we've got a younger population, that kind of 20 to 35 age group is the age group that we, for some reason, are dying. But we have all the same correlations in terms of opiates are the much highest, cocaine, benzodiazepines, pregabalin, alcohol. What we have noticed within the statistics within Highland is we've noticed there's generally some sort of life event that we've noticed within the drug deaths, some sort of upsetting situation trigger. So we added that onto our trigger checklist as being something that would identify someone as at risk.
Well, thank you very much. Thanks for all your work.
Thank you.
Thank you. And I can see, I think, Bob, did you want to come in on that question as well?
Yeah, I was just going to come in on that. Janice's point there about linking to other services. It's actually one of the biggest barriers our clients have is stigma. And obviously the link and the first point of contact with the service is often a big barrier for them, because it's when they make that initial contact that's like Leslie said, oh, are you going to treat me like the police? Are you going to judge me? And because of the way the support work and the trigger checklist works and the outreaches work, they very quickly will relate to us. And like Leslie was also saying there, a lot of the time when we do outreaches and we'll do an naloxone training and supply, it's not just for them that they're wanting to supply. They're like, oh, I've got colleagues that come round to my house at a weekend. Can I get a supply for them? Can I then show them what you've shown me? And we're like, yes, of course you can. And that then helps them engage with ourselves. And as a service, because we provide that friendly face almost and first point of contact for them, if they are struggling with housing, if they are struggling with food banks, if they are struggling with needing to get to Citizens Advice Bureau or not sure how to approach it, they're more likely to actually speak to ourselves and let us assist them to appointments and make that link, so it sort of cuts down the barriers or the stigma straight away, because they're like, well, they're not going to speak down to me if you're there with me. They can see that I've obviously reached out for the help, you're providing help to me, so therefore that automatically takes some of that barriers down and they feel more confident about going. So that's all I would like to add into that. So
that's brilliant. So that
Thanks,
really
Bob.
demonstrates how you're supporting them, the whole person, and not just in relation to the very specific service, but I think the word you used there, Bob, about taking some of those barriers away is really, really powerful. Mary, did you want to come in on that as well?
I actually did, just following on from what you're saying, Bob. So Bev Fraser, strategic lead, she's actually running another project right now on DNA rates within drug and alcohol services. And so far, it's maybe a bit early to say because we've not actually been able to discuss the data at great length, but our DNA rates are actually quite low in Caithness. And I do think that's partly due to having support workers on the ground in the community. The community know them and they know us through that, and they're supporting them into appointments, breaking down those barriers. So I do think it's a lot to do with the support workers in our team that our DNA rates are quite low compared to other drug and alcohol services.
I think I would really agree. Just listening to that, one of the things I wrote down, Leslie, when you were speaking there earlier, was that kind of strength of being in the community. And I guess, Mary, you've just kind of confirmed that for me. And I'm sure that's true everywhere, but I suppose it almost feels like in Highland, and it would be true in Argyll and Bute as well, wouldn't it, where we have communities where people do know each other and they know the faces and they know who's who. And actually, I think that really counts for a lot. And I know small communities can be really challenging with that. You know, you talked about that stigma, Bob, but equally then they know you, they trust you, you're a trusted face in the community. And I think that really goes such a long way.
We always joke that Willie, so our support worker who's been with us forever since the start of the drug and alcohol team up here nearly, when he drives up certain streets, they come out their doors and just flock to him. It's amazing.
Hi,
yeah, they literally, oh, Willie, can I just grab you for? So he almost does a wee drop in his car almost.
Yeah, but I think as well, and before, sorry, I know Philip, you've been waiting very patiently, but the other bit that strikes me around this, and it links to an entirely sort of different agenda that we've been talking about, but just that shift that you described there, Leslie, you know, so rather than waiting for stuff to come to you. You are going out, and you know that really embodies the principles of that early intervention, early support. Let's not wait until somebody's chapping on our door because they've reached a crisis point. Let's go and chap on their door and try and grab them a bit sooner. And you know, as well as just as you said, Leslie, that shows people you actually, you know, we do care if people live or not, if they have a good life or not. But you know, from a system level, that's exactly the kind of shift that we're trying to make is getting in there earlier, so we can do more for them. So I think that's really, really positive. Okay, obviously we've stimulated more questions. So I've got Philip next. I'll bring you in.
Yeah, thanks, Sarah. I just wanted to say thanks for the presentation. It's a huge amount of good work that's going on. And I recognise that this is an issue that we've had for many, many years. I was involved in the criminal justice side of it with the police. And what I would say is that my point of view, my opinion is that we actually need to look at this through a medical lens rather than a criminal justice lens. And it touches on what everybody was saying there about stigma and about gaining access to information and data. I would say that there are policy governmental approaches which I think need to be kind of taken at a higher level, a political level, but we're clearly in a political sphere here. So if there's anything of a policy kind of order or anything in terms of getting access to information, I think it's something through our partnerships with the community planning and with our connection with the national government that we should be looking to change that focus from criminal justice, where immediately when folk think about drug death, and there are, you know, complicated, tangled issues that surround that, but the first thing that people think about with drugs death seems to be the criminality of it rather than the therapeutic requirements and needs of those that are involved. So I think it would be good to change that focus. I think the board would like to be involved in helping change that focus. I just wonder if there's anything that we could do in the partnerships that we're currently working with to assist that.
Thanks, Philip. I can see Arlene put her hand up. I don't know, Leslie, we might let Arlene come in on that.
Absolutely.
Yeah, I think that would be the work that we currently do with the ADAP, the Highland Alcohol and Drugs Partnership, and the obviously the element that we are presenting on is relating to the DARS service, which is the medical kind of the treatment end of it. But as you say, Philip, it's a much bigger continuum and a much bigger issue and concern, and our DARS services works in partnership with ADAP, and we often what we're focusing right in with Leslie and our team is that frontline work of what people do on the ground, but there is a much bigger strategic landscape in relation to the work that we do with individuals that perhaps we're very happy to have a separate conversation, Philip, about how to connect that up, if that would be interesting.
Yeah, and I think I would support what you're saying there, Arlene. I think for me, it's not so much criminal justice versus medical, it's reaction versus prevention. And I think we almost need to step even further back in terms of policy and really think about how we help support people to not go down those roads. And at the very start, you know, how do we support children? How do we support not getting to the point of a non-fatal overdose before we're reacting? And some of that work is what we're doing, but obviously, as you've said there, you know, some of that is out with the bounds of the drug and alcohol service within Caithness, but absolutely the ADP are looking at that. Things like Planet Youth and the prevention models across internationally have got some great data.
Thanks, Leslie. And I can see Fiona wanted to come in on that point as well.
Yeah, thank you. Just wanted to say, first of all, thank you to Leslie and the team for the presentation, but I couldn't help but jump in on this particular point. I've been keeping quiet till now. So I think it would be fair to say that in Scotland, the policy focus on drug and alcohol harms is really significant. And Scotland has done things that very few other jurisdictions have done, like minimum unit pricing on alcohol, which is a really contentious area of policy because it affects everybody who is purchasing alcohol in Scotland, whether you have a problem with alcohol or whether you drink once a year and have a glass of sherry at Christmas. So it affects absolutely everybody. But the balance of probability in the way that policy has been taken forward is that the minimisation of harm that comes from it is outweighed by the, if you like, the impact on the broader civic experience. So there is a huge range of policy intention from, as Leslie says, those that are very much a public health approach, a preventative approach, through to very targeted interventions for those that are at the highest risk of the greatest type of harm or indeed death. Now, that doesn't mean there isn't more to be done, but I also think that there is a philosophical balance within society and within communities about whether we should punish people or whether we should treat them. And that's probably a debate that's as old as time. And I think our job is to respond to the policy as it's set by any particular government that we operate, but to influence that where we feel that our own experience or new and emerging evidence or our lived experience of the work that we do as practitioners that you've heard from the team could be influencing a better policy for the future. And in my experience, it takes carrot and stick. It takes a rounded approach. It takes prevention and response to really try to get to the heart of understanding what the root causes of this particular, the statistic Leslie gave at the beginning about the impact of this particular area in Scotland is so enormously disproportionate, even within the rest of the UK. Something is driving that, and it's, I suppose, on all of us to try and work out what that could be and to do what we can within our service delivery, but our public health and prevention approach and our partnership, where so much of that stuff is about social determinants of health, stuff that we're looking at through the population committee, that we need to keep that broad view as well as celebrating the work we've done on the MAT standards and the very targeted treatment approaches.
Yeah, thanks, Fiona. I think that's absolutely right. And I suppose again, not to overstretch, but thinking about the work that we want to do around refreshing our strategy and the focus that we want to put on, prevention, early intervention, population health, partnership, all of those things that Fiona's just mentioned. And I suppose the presentation that you guys have given us today actually gives us, more data, more ideas about how that might link up into that strategic development. Okay, we've got a couple of other questions. So Garrett, I bring you in next, please.
Yeah, I was just wondering, is there an addiction helpline or something like that, like the Samaritans, sort of national-wise, for people that are feeling like they're slipping back to the old ways? And obviously, addiction is addiction, and is, unless you actually have experienced it, is very hard for normal people, I think, to get their actual heads around. So I was just wondering, what the help is for people that can immediately get help.
Yeah, so within Highland, we've actually now got a partnership with you, who have, if you go online, just type with you, you will see they've got a workload across Scotland. But there's a special partnership between with you and Highland, so you do actually have a digital option as well. There is also the mutual aid supports, and then specifically for health services for NHS, you would still go through Breathing Space, Samaritans, and Mikey's Line. We do work with Mikey's Line as well. And they'll support into our service. But yeah, in Highland, we're still core hours services.
Thanks, Leslie. And I was really struck actually just to build on that by when you'd said about the lack of third sector. And I suppose and just while you've been talking, and I've been thinking about, I suppose you at the beginning of your presentation, you talked about how we have be not dissimilar picture in some ways to what you might see in an urban area, but really thoughtful about the difference in what we have in our toolkit, I suppose, to kind of address that in the round. And the point about third sector is really interesting. But and that obviously sounds really negative. It sounds like I'm focusing on what we don't have, but actually on reflection, that I think makes what you've just presented to us all the more impressive, in that, you know, you've taken the challenge, you've taken what you do have, and you've come up with a way to, you know, improve that service and reach in earlier. And to Fiona's point about, obviously we have to work within you know, the policy as it stands, and you know, we have to work to MAT standards and etc etc. But this has been a really good example of how we can still move the dial. You know, there are still things that are in our gift, and I think this is a really good example of that. Alex, I'm going to bring you in. Oh, sorry, go on, Leslie.
Can I just say, I think so. I've been working in the drug and alcohol team up in Caithness since 2008, and we've not had a third sector. We've got mental health support third sectors, but no dedicated, as I said, drug and alcohol, up until with NHS Highland, which is a very, very new digital support service. And in one way, you could look at it that, you know, it's a deficit, it's something we don't have. But I think within our service, it's almost made it a bit easier, because we can look at things and say, well, if we're not doing it, no one's doing it. You know, we don't need to go beyond that and try and work out who's doing it, or how do we build up some sort of service level agreement for, you know, passing information, or for we don't have to do that, because we literally don't have anything else. So if we're not doing it, and that makes that vision of what's out there and what's happening much clearer for us so far. Doesn't mean we don't want it, but
yeah,
whilst we don't have it, it's an easy way of looking at it.
Yeah, it's a really, really good point, actually. I hadn't thought about it that way, so that's actually really helpful to think about it. And I suppose is very, very kind of, it embodies, I think, the way that a lot of our teams in the Highlands and Argyll and Gyll Butte do things. It's a very much a roll up your sleeves and get on with it, because, you know, this is what we have in our community, and we're going to make it work. So I really applaud that approach. I think it's you're right, it's not to say we wouldn't want it, but actually you have done so well with what you do have, and I think that's a fantastic attitude. Alex, I'll bring you in, please.
Yeah, thanks, Sarah. Yeah, it just dawned on me as we were talking. You said right at the start of the presentation, Leslie, that Caithness, although it sounds like it's remote, you've got urban centres and you've got real rurality within it. In the data that you have in terms of harm reduction and folk that you're working with, is there a big difference between the real rural part and the urban centres in Thurso and Falkirk, Wick, etc.? Can you see that within the data, or can't you get into that sort of stuff?
I think historically we saw it more clearly, or certainly anecdotally we thought we could see differences between Wick and Thurso in terms of deprivation and drug use and alcohol use. I don't think it's that clear anymore. I think it's drug use is very widespread. It's very normalised, particularly when you think about cocaine, and you know, cocaine is used, you know, by a huge proportion of the population, whether you're in social deprivation or not, and it's a lot more affordable and available now. So I think probably we saw more of that historically, whereas now it's so vastly spread, and the kind of urban, yeah, I don't know. I think the whole of Caithness would be classed as, or drug use would be classed as urban. I don't think we've got little spots of it. I think it's quite spread. It's very, very different to when I look at the statistics for Sutherland, which is, you know, it's still very predominantly alcohol, and we have tiny pockets of drug use. We don't have that in Caithness. It's very spread out.
Sorry, I was pressing the mute button and it just wasn't acknowledging me at all. That's why I looked mildly panicked. Garrett, I'll bring you in, please.
Yeah, just be a little bit controversial. Is it time to start legalizing drugs so that they actually are a standardized, drug?
I'm not going to answer that
And
question,
then,
Garrett. I'm very sorry.
Maybe not for us to answer, Garrett.
That's a hugely political question.
Go on, Fiona.
Well, I was trying to save Leslie having to say exactly what she did beautifully say, which is that's definitely above her pay grade and my pay grade. That is a political decision for policymakers through the ballot box. Definitely not one for NHS Highland to be commenting on.
Okay, so I'm gonna round up. I'll bring Louise in just a second, just with a closing comment as well. Just from my own perspective, that was really great, and I think has reconfirmed my love of spotlight sessions. I think there's some stuff for us as a board to take away from that. Like, the way you guys have used the data to see the difference that you've made and to see where things are going right and going wrong. Actually, that's ever so helpful for you guys, but really helpful for us as well. We are an organization that makes decisions based on evidence, so I really applaud the way that you've used that, maximizing what you do have. Back to that bit about third sector, the way you're using your connections with the community, I think fantastic. And just that bit about innovating, driving us in that right direction around getting in there a bit earlier, that connecting with people, and the bit you said about relationships I think was really fantastic. But I'm going to bring Louise in as well. So Louise, I'll bring you in, please.
Thank you very much, Sarah. And I just, before I go to what I was originally going to say, I just want to reference and acknowledge the work of the Highland Alcohol and Drug Partnership and the organisations that they work with, because although the reference to the third sector organisation and the newness of that, there is some very firmly established Highland-wide work that I think it's really important to acknowledge in that broadest sense, because we do work in a truly partnership way with many organisations. But I just wanted to specifically focus on Leslie and mention the fact that Leslie has recently, as hopefully people will have spotted from communications, received the Queen's Nurse Award. And I just couldn't go without saying congratulations and well done to Leslie on that. And I know certainly some of the work she's been talking about is very much how she's used the Queen's Nurse Award to look at data and look at the services and actually take forward some really positive work. So I just wanted to say well done and thank you, and embarrass Linda. I'm looking at the wrong person. I'm embarrassed Leslie completely by A, giving her the wrong name, and B, outing her for the Queen's Nurse Award.
Thank you, Louise. I'm going to take your lead and further embarrass Mary and Bob, because Mary has actually just finished her advanced nurse practitioner. So she's been our trainee ANP for the last couple of years. Mary's a senior nurse within our service for a number of years. So a lot of the Queen's Nurse stuff that I've been looking on actually is the work that myself and Mary will be taking forward around how we support our OST patients particularly, but also our chronic alcohol patients, and how we look at public health priorities and make sure that they're not missed. So Mary will be taking a leadership approach with that work. And Bob, I think everyone here would agree with me that Bob has done so well this morning. He literally started in support work less than 6 months ago. He's never worked in care up to then, and he's just hit the ground running. He's here presenting it. I think is quite incredible.
I would agree. I love that he's only just started and you wheeled him out in front of the board early doors. Well done.
So there's two of them in the team that got the posts based on the outreach. So it was between the two of them. They fought it out and Bob lost. But he was absolutely delighted to come along, and yeah, he did really well.
Oh, well, we are delighted to have had you here. So, Leslie, Mary, Bob, thank you so much for giving up your time. We can tell, we know you're busy. The presentation has shown us that, but that's been incredibly helpful. Thank you so much for coming and presenting to us. We really, really appreciate it. And please pass on our thanks and well done to your other colleagues as well. No, they're not here, but we know that there's a lot of work that goes on behind the scenes. Thank you so much.
Thank you all very much. Enjoy the rest of your day.
Thank you. Okay, guys, great. Oh, that was really, really worthwhile. I'm very pleased that we got to do that. So fantastic that we were able to have that presentation. We're doing quite well for time. So I'm actually going to suggest that we take our governance and committee assurance reports and then have a break before the IPQR, so that we're all, rejuvenated for the IPQR and ready for that. So I'm going to do our committee assurance reports in order that you see them on the agenda. So Alex, first up, we have got FRP. So everybody in your pack, you'll see we've got the agreed minutes of the 14th of November and the 5th of December. And then we have a summary of the more recent meeting on the 9th of January. So any highlights, Alex?
Yeah, I'll focus on the two, because we talked about a bit the last board meeting about the one in November. But the two meetings that we held on the 5th of December and the second meeting on the 9th of January is where I'm going to focus. So financial position at the month end, month 7, was presented and discussed at length. The two main risks are still there: the adult social care partnership risk, funding that, and the risk for our own savings targets. But there was an additional one that Health brought in, and she'll no doubt discuss this in more detail in her financial report, was an increased charge from the Glasgow SLA, which is significant. Now, they're challenging it. Some pushback is going on, but there is a risk that that's going to push us even further over. In Fiona's report, we talked about environmental and sustainability, and we had an update from that team. And in the presentation, it was noted that there was a reduction in our carbon emissions, a slight reduction in the carbon emissions to the previous year. But there was also it was noted that there was an increased look at widening the emissions. It's not just carbon, it's not just net zero, but they're going to be looking at a whole host of other environmental targets. And that in itself is a little bit of a risk, because it's obviously widening what the team have to do. Utility costs have reduced significantly, and that's helping us a bit with the saving targets. But it was noted that sustainability in itself, to get major reductions in these emissions, it would require a substantial amount of investment, and clearly we just don't have that money at the moment. So it's something that we're aware of. Team's doing some great work in getting it down, but to actually get a major reduction, we're going to have to start spending some serious money, and I don't know if we can do that, certainly not at this moment. We talked a bit earlier about the resilience and incident response framework, which was good, and it was put into practice during that snow, and it's something that is being further developed in future, and we'll keep an eye on that as we move forward, both in terms of scenario training, etc. And then the last bit in that particular meeting, we had the annual procurement report 24-25, and there was assurance that all our statutory and legal requirements were being met in all the obligations that were being done. The good thing was we've got a new 5-year procurement strategy, and that's already influencing some of the decisions that have been made by the team, and it's improving where we are. So they're now moving into a wider awareness across the organisation to help in that regard. The early January meeting, we looked at the finance position in month 8. Again, the major risks are there, that hasn't changed. But the one thing that has become clear is that if you take those risks away, the financial position is stable and continues to be stable. So yes, it's challenging, but it's stable in and of itself. And as I said, Helen will be updating us later on in the agenda. We talked about the budget setting approach that was presented, and we welcomed that. It looks good in terms of how we're doing it and what we're doing and why we're doing it. The timeline was also discussed, so it's got to go to the Scottish Government early in February, and then we'll see the first draft of the FRP on the meeting on the 6th of February. We had a capital asset management update. Planned spend is on target and on track, so that should all be done. We also had updates on IPQR and operational improvement plans, and we'll hear more of that through the rest of the year. And I think that's me. Thank you.
That's brilliant. Thanks, Alex. And yeah, as you said, obviously we've got the monthly position later on in the agenda. And also just like to note, maybe more for kind of newer board members who don't know, FRP meet monthly. So it's a very frequent meeting. And particularly, I suppose, if any of our newer board members want to join to get more into the nitty-gritty of the finance governance work, then that is available. Okay, any questions or comments for Alex before we move on? Oh, okay, thank you for that update. That's great. Next, we're going to go to staff governance. So we've got the agreed minute of the 3rd of November, and then we've got a summary of the more recent meeting that took place on the 13th of January. And I think, Steve, do we have you for some highlights?
Yeah, so Philip was on his hollybob, so I stepped in as vice chair. First thing I'd say is a big thanks to the team. They're putting these really helpful notes together after the meeting, which really helps you when you're chairing the meeting. So we had a spotlight session from the Director of Psychology, and I think the key point we took from that was that the waiting list in that area has gone from the worst performing to top 3 nationally. So that was a real highlight in terms of just giving credit to that part of the service there. Really impressed with the contingency work that was done in preparation for potential strike action, which of course was called off at the last minute. But I think that we were ready. Sorry, NHS Highland was ready. I feel we is the right term. Thankfully not needed, but I think noteworthy nonetheless. So big thanks to the teams that pulled that together. From assurance perspective, some areas of ongoing concern. Appraisals are stubbornly low. Leadership and culture training is something that the committee have been focusing on, and safe staffing data all requiring attention. So on a positive note, the staff governance monitoring report, a return, went in, I think, on time just about this year, which is a big improvement on what happened in previous years. And I think from Gareth reflects on a big improvement in partnership working and how that's going. We had a substantive discussion on the impact of caring responsibilities on our employees and the consequence on workforce planning. And the committee would like to request, I think that will come through Gareth and the team, potentially a future board development session to just discuss how our policies match up to supporting staff that have got that type of commitment in their personal life. And we had a really, really positive discussion about it, but definitely an area of concern. So the committee looking forward to seeing a change in approach to appraisals and to how we deal with violence and aggression training. Those are areas that the board feel we need to focus on going forward. And those items requiring further scrutiny, I think they're covered in the action section. So back to you, Chair. Thank you.
Brilliant. Thank you, Steve. That was great. Any questions or comments for Steve or in relation to the staff governance work? Gareth.
Thanks, Chair. Probably just a slight nuance to in terms of staff governance monitoring return. We are slightly overdue with it in terms of the Scottish Government deadline, but we had updated them to let them know it was due to consideration going through our governance cycles and not aligning necessarily with the submission timelines. Just for accuracy, just want to highlight that. And Also, just to highlight that a big focus of our work on an ongoing basis will be part of the action plan associated with staff governance monitoring is to continue to look at improving partnership working across the organisation. So the progress this year has been positive in terms of agreeing a staff governance monitoring return and an action plan and having a group set up and put in place to progress that forwards. But I think it's worth noting that part of that is still continuing to look at how we improve partnership working across the organisation. Again, just a point of accuracy.
No, that's really helpful. Thank you, Gareth, and pleased to hear that. Good. Okay, any other questions or comments in relation to the Staff Governance Committee? No, okay, thank you, Steve. Thanks, Gareth. Next, I'll move on to the Highland Health and Social Care Committee. So we've got the minutes of the 5th of November and a summary of the more recent meeting on the 14th of January. And I'd like to invite Jerry to speak to this, please.
Thank you, Sarah. Yeah, probably a few things which are set out in the summary of the meeting on the 14th of January, which I'll just pick up. I won't cut across anything Helen might say in relation to finance, but I think we continue to note our worries in terms of not probably the speed of progress in terms of delivering the savings challenges that we've got, but I'm sure Helen will expand on that. We had our annual Children and Young People's Report presented to us by Ian Kyle, and Ian spoke specifically and gave us some specific assurance at the committee's request on the promise, because there had been some difficult conversations about that nationally. So, but Ian gave us some good assurance on what we're doing locally, which was very helpful of him. There was a little bit of concern in terms of the timing of the report and the availability of specifically health data, and we seem to have a mismatch there. So we did note that we probably just need to make sure that that data is included in future reports, because we had quite a lot of gaps so we weren't able to see specifically in relation to health. We were given a really good report on level 2 risks by Arlene and the team. And I think it's fair to say, just as we follow on from the Staff Governance Committee, that workforce shortages featured prominently amongst the level 2 risks, and the lengths people are having to go to fill gaps and work with depleted resources, which I think is to everyone's credit. But and I don't think we're saying anything new. Everybody's is aware of that. But I think it's helpful that it's featuring on risk registers. Doesn't make the problem go away, but it's helpful at least it's featured there. Gareth and the team brought us the annual report on the engagement framework report, which we took moderate assurance on, but the moderate assurance was driven primarily by the volume rather than what we were doing. And I think that was recognised. And as we see, hopefully what we'll see is that volume pick up, especially as we move through models of integration work, we move through the strategy development. I think we'll see that. I'm quite confident we'll actually see that pick up, and actually we'll see the processes that we'll put in place really begin to generate some good engagement there. And thank you to Arlene. We had a very early version, and we do recognise it as an early version of the draft commissioning strategy. And we didn't have a lot of discussion on it. What we really asked committee members to do was to feedback directly to Arlene. I think the initial thoughts was it was falling a bit betwixt and between whether it was a strategy or whether it was a plan, and we probably needed to make sure we were very clear on what it was trying to do. But it was really great to see that work beginning to come to fruition, because I think we've spoken a lot about that in the past in terms of needing to give that focus on where we spend that money and how we commission moving forward. And really I just want something I had written down, and I will echo it. It was just really just to specifically raise the Highland 4x4 voluntary responder service and all the support they gave us over the snow period. I'm just really picking them out because of the volume of incidents help that they were able to do. And I think it goes back to exactly what you were saying, Sarah, in terms of that community response. I think it just highlights that again. So those are the key points for me. Thank you, Sarah.
Thanks, Jerry. Sorry, the very, very slow mute button today. And just let everybody know, my power is flickering, so it's a bit gusty outside. If I suddenly disappear, that's what's happened. I haven't just had enough. If that happens, I will try and find a power source to rejoin you as soon as possible. Just a heads up, Jerry. Okay, does anybody have any questions or comments for Jerry in regard to the Highland Health and Social Care Committee? No, okay, thank you, Jerry. And I'll move us on then to the Clinical Governance Committee. And we've got the agreed minutes of the 6th of November, and we've also got the summary of the very recent meeting on the 15th. So I will invite Karen to give us some updates from this, please.
Thank you, Sarah, and I will say the same thing. My power is also a little bit juddery, so, you know, bear with. We're just across the water, Sarah and I. So I think the theme of our 2 meetings from November and just last week, were really operational pressures, resources, staffing and facilities. And I think that's becoming increasingly noted in reports that we're in papers that we're seeing coming through. So I think that's just in general, that's something that we need to be paying attention to. Just when you compare and contrast, you can really see that starting to be highlighted increasingly, and I think that speaks to Jerry's points around risk as well. So we had a paper on audiology services, which we were able to hear about the challenges, again, some of the things that are happening in that service, but also the fact that it's now receiving more of a national focus. Health services in general are going to be receiving more of a national focus. So I think that's something we just need to bear in mind moving forward. Dental services, we had a really interesting paper in November, which again talked about the challenges of delivering NHS dental services, but what was particularly interesting was around the areas of deprivation. And so we've asked that the next update includes the public health data, because I think that will really help to tell that story in more detail. So that's something that we'll see at the 6-month point. Ongoing information around NDAS in the North and North Highland Neurodevelopmental Assessment Service. There's been a lot of work in that area across the wider system, and so we'll continue to hear how that's progressing. It's not going to be a short-term fix, but actually potentially it's a whole new approach, which will hopefully potentially be positive for the future for how we deliver those types of services across the whole system. We have the maternity and midwifery services, similar points around resources, staffing and facilities, but again, that national focus with the national task force. So there's preparatory work happening in the service around enhancing existing governance and oversight arrangements, but actually we haven't got the detail of that task force, I think, as yet. Some of our clinical execs may know more about that than us if anyone's got any specific questions. The Cancer Services Workforce Report, we gave limited assurance. There is some fragility in that sector, and I don't think it was unexpected. It will continue to be part of the regional planning approaches at this stage, and obviously there will be, I'm sure, a real people will be looking at that regularly and we will get further updates as and when we need it. The next sort of bit is about our annual screening report, and I think that's something I would recommend that people have a look at, because I think that also tells a story around pressures and resources and staffing and the availability of staffing across the system. And I think when you can then look back at cancer services and how they all kind of join together, I think that's again telling a story when you start to look at it in the round. So again, I would really recommend people have a look at that report, because obviously that again is back to that how we look at population health and how we take that kind of wider view of getting in early, as we've discussed in our previous session. The areas of managing and responding to complaints, and duty of candour I'll take together. The duty of candour, we had an annual report. I think both of these are areas where there's work to be done around our response rates and how we manage that from the perspective of how well trained our staff are to work in that area, and we really need to find ways to improve our responses and our response time. We had a report in November around an annual report on care inspections, which Louise pulled together, which was really helpful and something that we hope to see more of, and how we can again pull all that information together and use it across our whole board, because I think the learning that we get from different inspections really can inform and improve how we do things in other areas. So that's something that we're looking forward to seeing develop, and that will all sit underneath the new clinical and care governance senior leadership quality assurance group. I think Louise gets the award for the longest group title there of this meeting anyway, and I think that is a new group that's been established to support the work of for clinical governance and quality, and that will help our operational colleagues to have a route through. So the mapping of that will be something we'll see in our terms of reference. And we have also a new Associate Director for Quality and Clinical Governance, Laura Neal, who's joined the team, and again will be helping us to pull all of this information together as we move forward. So there's, as usual, a huge amount of work going on. As we've all said before, we're asking people to do a lot with maybe a little bit less, and that's tricky, but it's very appreciated. Thank you.
Thank you, Karen. And yeah, it was you covered a lot at that last clinical governance meeting. It was very impressive. Okay, any questions or comments around the clinical governance committee? Louise.
Thanks very much, Chair. And just to say, I'm in Campbellton, so that it seems that we're swaying towards the wrong side of the right side of Highland, whichever way you want to put that. So just to reference, Laura's in the room today for her first board meeting, as you mentioned, Karen, so that she can get a real sense of. She's been to most of the committees now. She's getting a real sense of the organisation, which is going to be hugely helpful as we plan forward. And as Karen's referenced, that the first of those meetings, we've already seems to have dropped the systems leadership bit from the title. I think it's going to be a bit smaller soon. We've already had one of those meetings. We've got another one planned, and I think that whole opportunity for operational and professional leads to come together is going to be hugely helpful, both for the committee but also for the organisation.
Thanks, Louise, and welcome, Laura. Lovely to have you here. Boyd, I'll bring you in, please.
Thanks, Chair. And Karen has given a comprehensive overview of what was a very detailed meeting. And I just wanted to further mention to board that the reports that come from the HSCP, from Argyll and Bute, and from Acute Directorate do cover a great deal of detail. And that will include some of the system pressures, which Chief Executive mentioned at the opening report this morning. And also there are some ongoing areas which have been reported to board previously, such as our vascular service as it undergoes change that's been made necessary by recruitment challenges across the whole of the UK, and assurances around safety of such services is brought into the Clinical Governance Committee so it can undertake its job of making sure that everything that can be done to maintain safe services, despite all of the pressures which Karen and others have mentioned, will always be at forefront of the committee's work. And I just wanted to mention that particularly the system pressures and examples such as vascular service, which have been previously reported in board meetings throughout last year and the year before. Thank you.
Thanks, Boyd. Okay, any other questions or comments for clinical governance? Oh, okay, thank you guys for that summary. So I'll move on to Area Clinical Forum. We've got the minutes from the 6th of November and the summary of the meeting on the 15th. And I'll invite Alison in to give us highlights, please.
Hello, Chair. Hello, everyone. basically the summary of the meeting that happened on the 15th. The subject matter that we discussed was realistic medicine, and obviously that is a foundation that we want embedded within our system. What became aware to us that our funding for realistic medicine does actually go on some of the completion of the TORAS models that we do have on our system. So that's something as ACF we're going to highlight with our professional committees, and also to highlight across the system. Again, like everyone else, and Karen alluded to it, systems pressures and risk came up as one of the key subject areas within the meeting, particularly in the North Highland acute sector, significant pressures across acute care, especially in discharge and flow. It's also quite apparent that the system pressures are affecting the attendance of ACF. So key people around the table for the discussion, Jerry was at the meeting with us, were not able to attend because they were compromised in terms of having to attend to clinical duties rather than ACF. We've also got representation gap within the committee from optometry and Regmore representation, and it's inconsistent and does impact on the advisory function. We're also made aware from optometry and pharmacy that a lot of the professions work in big national companies, and therefore we do not get representation because they will not release them for professional committee work in any shape or form, which is a bigger issue that we need to explore. We want to assure you that there was presented the nursing midwifery and AHP advisory structures with the new structure and the split that's going on, so that assurance given and the terms of reference for the nursing and midwifery were passed to go back to their group in further relation to that. And we also like to assure you in terms of the national alignment of realistic medicine in work streams that is there, but we do need to advise you on the engagement via clearer communication and leadership messaging, because I think it's just kind of seen under the umbrella of medicine, but it's everybody's business, and so that sort of marketing almost of realistic medicine and where that should be put across the system, because it does improve quality, it does decrease financial impact on services. In terms of risks, we said about the funding of realistic medicine, acute system capacity and flow pressures. There's risk related to inconsistent representation on ACF, and also the feasibility with risk within population health. Unfortunately, because Jerry was at the meeting, we're able to talk about it. But again, I think there's just a gap or a disconnect between the population health strategy and the professional committees, which we're trying to align. We are also going to be looking and advising you on, we're going to standardise our governance templates for the professional committees, so they are all standardised and more contemporary for purpose, because we're also looking at our timings and our response to the board, because every other month in terms of response is not enough. So we're looking at addressing that if we can put in a monthly meeting that is not all the business as usual stuff, but is there a response needed either from ACF or from the board that can be dealt with in the here and now in a quicker way, and with our professional committees. And the actions is that we are going to promote the TORAS model, and we're also going to develop the terms of reference within the subgroups, and obviously get some standardisation to our professional area committees for our governance structure. And we're also going to address some of the representation issues that we've got.
Thank you, Alison. That's a really good summary, and you and I have discussed some of that offline as well about how we support ACF. And I think the point you've made about sort of how fleet of foot ACF can be and how we make best use of that is points really well made. So we shall watch with bated breath as that evolves.
Yeah.
Good. Any questions or comments for ACF?
I would just like to highlight and give the board assurance that the next meeting in March, Louise Bassal is attending to talk about the system risk and pressures with the professional area committees. So that is on the agenda for the March meeting on the 6th, Sarah.
Excellent. Okay, that's good. Okay, not seeing any other comments or questions. I'll move us on then to our Population Health and Planning Committee, another one for Jerry. So we've got the agreed minutes of the 2nd of October and a summary of the 14th of January. Jerry, please.
Thank you, Sarah. Yep, I think it's fair to say we're still finding our place as a committee, but we had an excellent discussion there a week or so ago. And I think we've already heard this morning that I think people are very well aware now of the existence of the committee, but more importantly, our approach to strategy development. And I think there's a genuine enthusiasm out there for that population health, addressing inequalities approach. And I think there's going to be a lot for us there in terms of, as we move forward, to make sure that we fully engage with all of those interested parties and bring all of that in. But just looking at the business of the meeting, we got an update on the framework timeline. And we've agreed to revise. We were hoping to hit March 2026, but we have rightly agreed. I think that actually May, June 2026 is probably a more realistic timeline in terms of that delivery of that initial framework, for a whole variety of reasons, not least of which is the significant operational pressures which everyone has been dealing with over the last few weeks, and now sensibly as we move into the pre-election and then the election period, we know that will impact on our time. So I think May, June 26 is that. I think we've still got a high level of confidence that I'll say no more than late autumn of this year, we will have a good draft strategy for us to be getting to talk about and work our way through and take through the various discussion and engagement processes. So I don't think we're impacting at all on our timeline of delivery for taking that into 27, 28. And I think that's the first time I've used that yet, 27, 28 as opposed to 26, 27. It's not even started. Counting my life away. I think we also had an excellent presentation from Ian Ross on the coming forth My Care Act, which we will have in NHS Highland in April, albeit in limited form and not quite what they will have in Lanarkshire. But that really, I think, the important thing for me in that discussion was really, I think, as Ian took us through the slides and what could be there, actually people started thinking about the change in mindset that it might actually start bringing in our population, and how people might start interacting with health services once they have access to various pieces of data, which, not to say that they don't have access at the moment, but actually to start to see it all in one place. And I think will start people thinking about, well, how do I get other data and how do I bring that forward? And I think we really need to take that. We have to think about that. To me, has been a lot more than just an app. It's actually something I think which actually might change the way that people think about how they interact with health and care services moving forward, and take that in timeline. I don't think we don't have a clear idea of the workload which is going to be involved in with the app at the moment, but I think Ian quite rightly is flagging up to us it will be significant, and we've got to give assurance to our government colleagues that we are prepared for that work, and I will leave that to Ian and David to take that forward. So I think now that we've had a couple of meetings of the committee, we're probably getting to get a clearer idea of how the Population Health Committee can work. I think we've got some work to do in our terms of reference. I think we've got a piece of work to do in terms of thinking about how we make sure that we retain the role as an assurance committee, but also an assistance committee, if I might say it, something like that, and how we actually interact with services. But I'm very conscious that we can't get into marking our own homework if we're actually providing a level of assurance to the board in some way. So I will ponder that, and I will ask others to ponder that as well, and think about that as we move forward. But I'll leave it at that, Sarah. Thank you very much.
Thanks, Jerry. That was helpful, and I know I would absolutely share your reflections. It's really, really positive that we've got that committee up and running, and there is just a bit of embedding that needs to take place. And I suppose I'm conscious of the wider work that we're doing around kind of mapping and streamlining our governance, and actually how we need to take cognizance of the committee while we do that as well. Okay, any comments or questions for Jerry on the Population Health and Planning Committee? Okay, thank you, Jerry. We've got Audit Committee up next. So we've got the minutes from the 9th of September and the summary from the 12th of January. And I'll invite Emily to give us highlights, please.
Thanks, Sarah, and I'll jump on the Argyle bandwagon and say my lights are also flickering slightly ominously, so hopefully I can stay with you. The committee met on the 12th of January. First of all, delighted to say that Bert has been nominated and indeed accepted the role of vice chair, which is brilliant. So thank you for that. We were carrying a vacancy for quite some time, and we're also really pleased that Brian's joined us on the committee, so that was his first meeting as well. We considered 5 reports from internal audit. The resident doctor's rota compliance report, which was originally came to September, but was discussed in more depth at the January meeting, and we will bring it back later in the year just to get a progress update. But there has been considerable progress made already with the actions in relation to that report. We also had a report on remote access, one on third sector allocations, one on operational performance and compliance monitoring, and one on financial management and savings plan. So quite a lot of business to get through in that meeting, various findings and actions arising from those, some of which are already very well progressed. I would just like to make the point that a change in the audit standards has meant there's a lot more recommendations coming out of each review, just because they're trying to break them down into more granular parts that can be owned and delivered in stages, rather than having a sort of whole system review that's got a deadline a year in the future. We're trying to make sure that we break things down, and that's a change in the global audit standards, which will affect any organisation, but just for people's peace of mind that the massively increased volume of actions doesn't necessarily mean that the environment has deteriorated. That said, internal audit did briefly discuss the current year's opinion and signalled that the volume of and materiality of actions raised was something they were considering. They haven't highlighted that there's likely to be a change or deterioration in the opinion at this stage, but they would be looking at progress made with the various recommendations between now and the end of the year, just when they come to forming their opinion. We also had at the meeting a review of progress and challenges with implementation of the risk management framework from David, and we're discussing how the audit committee can track progress with this in future. The internal audit plan for the coming year is also evolving. It's having input from EDG at this point, but audit committee members will also have a chance to input to the themes before it's finalised in March. And we also had an interesting discussion around some of the internal audit reports we considered at this meeting contained recommendations that we re-evaluate either the content or the impact rating of some of the risks on our corporate risk register. And from the meeting discussion, it wasn't exactly clear at what point we would trigger that sort of review and how we would take that forward. So that's something that we need to look at, just if we do get something highlighted by internal audit. Obviously, it's for those tasked with management of risk in the organisation to decide what they do as a result of that, but it's just making sure that those trigger points do mean that we evaluate the things that we're being asked to look at. Finally, just I guess a plea. We had to delay the December meeting, unfortunately, because of the various reports not being available in time. We have had some concern raised by internal audit that a few of the reports that are due to come in March may not be available in time. So I just ask those who are either sponsoring or involved in providing evidence for the ongoing audits, if they could just try to ensure that those keep moving forward, just to make the best use of audit resource between now and the next meeting. Thanks, everybody.
Thank you, Emily. And I suppose just on that very last point, I know that Nathan and Dom and others will be supporting behind the scenes, and if we could just keep a watching brief on that, please. I think it's imperative that we keep to our audit schedule, and take on Emily's point about sponsors having a look at that and making sure we can get what we need for the March meeting. And thank you, Emily, for explaining the change in the global approach to the recommendations, because you're right, we could have got a bit of a fright otherwise. So that's really helpful to understand that the future they'll be broken down into a more granular level, which I'm sure will be helpful. Gareth, I'll bring you in, please.
This may be something we want to pick up in future conversation with the audit committee, because I think there's a linkage between the point Emily was making in relation to the change in the standards and then the experience of undertaking and working with audit. So we are certainly, I have 2 audits at the moment that I'm got 3 audits actually, which which I'm progressing, and the volume of information that's been requested has significantly, I would say, significantly increased. And that's I suppose there's a relationship in terms of that challenge, in terms of timelines and resource. So that's something we can pick up within conversations in the audit committee, I think.
Thanks, Gareth. And again, another thing to, I think, to be factored in offline is a conversation that we had I can't remember when it was, in some development space, maybe about the audit plan and sort of the ambition around the audit plan, and you know, things, work that we want to get through, but taking cognizance of the, you know, all the pressures that we've talked about in various other bits of this agenda, and to your point, Gareth, about that sort of that shift, that increase. So yeah, I would be supportive of us taking that offline and having a think about what that means for us in terms of, you know, the practicalities. How well can we fulfill that? What do we need to consider to make it more deliverable? But Emily, I'll bring you in.
Thank you. No, just to note, I do understand that, Gareth, and I think that's something that we're really looking to factor into the internal audit plan for the coming year, to make sure that we're being realistic about timelines, and also when deadlines are set for the completion of recommendations. As Karen said, we are asking people to do an awful lot, and I think it's important to recognise that it might take longer to get things done than usual, and we'd always far rather have an action with a realistic deadline than one that gets rescheduled 5 or 6 times, as we have seen with quite a few things that we've had to look at audits. So yeah, I think we're aware, but just if that could feed into the current planning approach, that would obviously be great.
Okay, thanks, Emily. Okay, any questions for Emily on audit? No, okay, thank you. And then last but definitely not least, we have the Argyll and Bute Integration Joint Board. Graham, I'll bring you in to speak to this. We obviously have the minutes of the 19th of November, and as always, our timing is impeccable because you have the IGB tomorrow. But Graham, I'll bring you in to give us any highlights. Thank you.
Yes, thank you, and I'll try not to keep you from your coffee breaks too long. Just to highlight, that meeting was held in Helensburgh. And tomorrow's meeting's Campbelltown, which are almost the 2 extreme mainland points of Argyll and Bute, and 2 very different communities. We always have a local focus, and we were doing a kind of more in-depth look at some of the issues in the Helensburgh and Lomond area, which for those of you not familiar, Helensburgh is sometimes regarded as a commuter town of Glasgow. So very different from many other parts of Argyll, and indeed often dominated by the big nuclear submarine base, which has 9,000 employees. Helensburgh has 13,000 of a population, so big impact stuff. Just on 3 points just quickly to highlight. We began our in-depth look at our budget, which is challenging for the year and is being continued again tomorrow. We also had our annual public health review, where again we were reminded of you know, just the very wide range of factors that go to population health, and it's one that we just constantly need to be mindful of. And I was reminded, just as we were hearing in our spotlight this morning, about the alcohol and drugs partnership work. We also had our annual review of that in our November meeting, of the work being done in Argyll and Bute, and you know, it reminds you of just the complexity of many of these issues, but how, you know, the social isolation and other kind of life factors come in so much into these areas, and reminded of the importance of relationships in the work that's done. But I know that my colleagues, even across the medical field, also understand the importance of relationships as well. It's not just the more technical aspects of medicine, but these were the highlights from our November meeting, and they're there for any comment or question.
Thank you, Graham. And well, hopefully when you come to Campbelltown tomorrow, there'll be power. Maybe bring some paper just in case, and a torch. Okay, good. Any questions for Graham for the IJB? No, lovely. Thank you to all my committee chairs for those updates, and to committee support services for pulling all that data together. No mean feat. That's good. So we are being asked to confirm that we can take adequate assurance from our board governance committees and our area clinical forum, and note the minutes of the IJB. Are we all content with that? Lovely. Okay, it is 11:25 on my clock. Let's take a 15-minute break and we'll come back with a spring in our step for the IPQR.